welcome everybody to this webinar live from Paris, from the PCR studio. We are very happy to welcome you. The topic of today are pacemaker leads and tricuspid intervention, a topic with some knowns and a lot of unknowns we will try to address during this PCR tricuspid focus group webinar. I am extremely happy to be surrounded by a fantastic team. My name is Fabien Pray. I'm an interventional cardiologist from Bern University Hospital, and I am with Jean-Claude Deharo. Hello, Jean-Claude. Thank you for being here. Jean-Claude is an electrophysiologist, specialist in lead extraction in Marseille, France. Then on my left, I have Julien Dreyfus, an imaging specialist from Paris. And we also have online from Montreal, Blandine Mondésert, who is also an electrophysiologist, so an interdisciplinary team to talk about pacemaker lead. The content of this webinar will reflect a recently published paper, which is a collaboration between the European Heart and Rhythm Association, the ERA, and EAPCI as a scientific statement that you will be able to read in EuroPace and EuroIntervention. It has been published in both journals, and that we will try to explain and show some of the figures as well of this very nice paper that have been shared by Jean-Claude. Jean-Claude, I give you the word to address some instruction to our participants.
Welcome to everybody to this webinar. We are very pleased to be with you, and we would like to really share with you valuable insights. So do not hesitate to ask questions on the chats, which is very important for interaction today.
So we will give priority to your question. We have discussion, of course, between us, but the goal is really to have your input, your question, and to try to answer this question. So the first step when you have a lead and a tricuspid valve are the diagnostic of interaction maybe, and also prevention of interaction, and that's a part of Julien Dreyfus. Julien, it's your turn.
I'm going to talk about valve-lead interaction, diagnosis, and consequences. So first, you have to know that mechanism of TR is currently divided into three groups. First, functional or secondary, second, organic or primary, and now there is a new group for patients with cardiac implantable electronic device. Approximately 1/4 to 1/3 of patients with severe TR have a pacemaker or an ICD, regardless of the medical, surgical, or transcatheter group. It's very important to distinguish two situations. The first one is lead-associated TR, meaning patients with no clear causative relationship between CID and TR, and patients with lead-related TR or lead-induced TR, meaning there is a causative relationship between CID and TR. And I will display several examples. One example is patients with a perforation of the septal leaflet at the time of implantation of the CID. Another example of patients with prolapse of the septal leaflets due to chordal rupture at the time of the implantation of the CID. After extraction, unfortunately, and we are going to discuss it further, may appear damage of the leaflets, frequently the septal leaflets and significant TR. And this is the most frequent situation with impingement of the septal leaflet by the CID. And you can see that unfortunately the lead prevents the correct closure of the leaflet, the septal leaflet in systole. And unfortunately, with time may appear some degree of fibrosis, making that even after extraction, sometimes you don't have a correction of the motion of the septal leaflets that remain immobile. Another frequent situation is the adhesion of the lead with the leaflet. For instance, here, the adhesion between the lead and the anterior leaflet, meaning that there is a common motion in systole and diastole for both the lead and the leaflet, and that is also nicely shown with the histopathology. And for those patients, you will, and we are going to discuss this further, may consider transcatheter tricuspid valve replacement. Here is an interesting example of patients that was treated efficiently for CVTR at the anteroseptal level with 2 clips, but unfortunately the posteroseptal part was not treated, while there was a significant TR at this level where was located the pacemaker, and probably this patient should not be considered anymore for this type of intervention, and we should prefer transcatheter tricuspid valve replacement. In this situation, we have a pacemaker lead located at the anteroseptal part between the septal and the septal leaflet and the anterior leaflet. And unfortunately, in this situation, even if the lead is not inducing TR, this is not a good candidate or not an optimal candidate for an edge-to-edge repair. And we show this unfortunate case where we cut the pacemaker lead with the clip instead of the leaflets, meaning how difficult it could be in those situations. On the contrary, you have here probably the best situation with a pacemaker lead that is located in the commissure between the septal and the posterior leaflet, meaning the perfect location because it is not inducing TR and it won't prevent any implantation of the clip at the anteroseptal or even the posteroseptal leaflet, so a good candidate. It's also important to know that deferral leads are frequently bigger and associated with poor image quality compared to pacemaker leads, so this could be challenging, as well as several leads. The more leads you have, the less the probability to be successful in correcting TR with transcatheter intervention. So to conclude, TR and CID is a very frequent situation. We need a good understanding of the mechanism, and imaging is key. And we need for a dedicated management with our team, and that's why we are here today.
Yes, thank you very much, Julien. Very nice presentation, very nice images as well. Congratulations. But I saw only echo images in your presentation, and I'm sure the people looking at this program ask themselves whether other imaging modality could play a role also to detect the position of the lead, to detect interaction with the leaflet. So, for example, CT scan, that is giving a lot better resolution, I would say, compared to echo, maybe one of these modalities. What do you think? Is that something you are using in your practice?
I would say yes and no. First, we are beginning with transthoracic echo, and I would suggest to use 3D as much as possible, even with transthoracic echo, because we are able to have good image quality. If not sufficient, we use transesophageal echo, especially with the transgastric view, which offers very good temporal resolution. But I agree with you that the spatial resolution is very good and even better with CT. And now we are more and more performing CT, especially before any transcatheter tricuspid valve replacement. So CT modality is very, very interesting and could help us to define the perfect location and also the interaction with the device that we would like to implant. So for the screening process, it's a very useful tool.
Yes, Julien, I have a question for you. The images were fantastic. Do you think that we need transthoracic echocardiography in all patients, or we have to go to transesophageal echocardiography in order to know if the lead is really causal of the tricuspid regurgitation, which is really a key question in our clinical practice?
It's an excellent question and not an easy one. Transthoracic is very useful, but sometimes you don't know if the TR is induced by the lead, and transesophageal could be much more powerful. So I would say that mostly you can answer with transthoracic, but it's not uncommon that you need a transesophageal. So I recommend transesophageal echo as much as possible, if doable.
Okay.
So I think people looking at it at this program and at our discussion may also think we need to avoid then this kind of interaction. We need to prevent them. So what could be the strategy in that situation to improve the implantation in order to be able to not being facing the situation of a significant interaction?
I think that's also a very important question and not easy to answer. Well, I would say that, and something that we have previously discussed, is that it's very important that EP colleagues are aware of the fact that when they are implanting pacemaker or deferral lead, ideally it should be interesting to have a transthoracic echo before to know if there is a significant TR, knowing that frequently you are treating a quite elderly population and TR is not infrequent, because if we are facing severe TR, probably we should discuss the strategy, and especially should we implant pacemaker lead pacemaker with lead crossing tricuspid valve or a valve sparing device. So I don't know what you think about this, Jean-Claude. But...
Yes, this is exactly the question I wanted to ask you. How do you do in your clinical practice when a patient with a severe TR has to receive a device? I mean, in advance, before any intervention on the tricuspid valve, do you recommend your EP colleagues to go to a valve sparing technique in all cases, or are there some arguments for choosing specific patients?
To say that in all patients won't be fair, but that we think about it for all patients is true. And whenever possible, if we truly believe that the patient may be implanted with a device, a transcatheter device, if possible, we prefer a situation and solution with a valve sparing device, whenever possible. And I think it will be the future.
Maybe it's important to define what is valve sparing. That's something we will discuss more during the webinar. But valve sparing means that you apply a technique of pacing without a lead crossing the tricuspid valve. And that gives you, or that eliminates the risk of having an interaction. And we will discuss this with Blandine a little bit in more details. But let's say you need to have a lead crossing the valve, and in some situation, of course, that's the case. Would be guiding of the procedure, Jean-Claude, when you implant a pacemaker, to have an imaging specialist like Julien giving you advice where to put the lead? Would that be nice to have, practicable? What do you think in your lab?
Well, I would say that in clinical practice, I don't think it's doable from a general point of view. We have many patients coming from urgent implantation, first of all. We have patients who are not really unscheduled, so it's very difficult to think about having an echo specialist every day in our practice for guiding our implantation. I don't know, Julien, what is your opinion about this question?
I fully agree with you. First, I'm not sure it's feasible. And the second point, I'm not sure it's useful, because at the end, but you know better than I as EP, usually the lead could change its position even during the intervention and the day after. So we don't really know what we are doing.
Okay. Maybe we can ask Blandine as well, on this. Blandine, can you hear us from Montreal?
Yes, good afternoon, everyone. Actually, in our institution, we
have all the
almost
echo for the control of the implantation during the implantation, which I think is much more difficult. What is your practice on this?
Can you hear me?
Yes. Yes.
Okay, perfect. So we used to have almost in all cases the TT before the procedure. So in case of TR at that time, we discuss what we are going to implant. Having the guidance at the echo during the procedure, I totally agree that I don't know what I can do differently to avoid the lead interaction with the tricuspid valve. And so far, we don't have any protocol to check the TR after the implant, but we are more and more often asking a TTE around 6 months to 1 year after implant, just to check if there is not huge TR after the lead crossing the tricuspid valve.
So I think these are extremely important messages. I think the two very important messages is first to look at the valve before crossing the valve, and then to discuss together if there are relevant TR before putting a lead that may preclude further intervention in the future. And then the second point is, of course, to adapt then the pacing strategy and then to control the patient. I mean, that's something we are advocating in the paper, Jean-Claude, to have an echo after implantation, maybe 1 month, 3 months, just to make sure that we are not creating a big interaction with the valve that cause very severe TR. Because in that situation, and I want to have your opinion on this, you may be able early to take the lead away or to replace the lead in order to avoid this interaction.
Yes, definitely, yes. I think that from a technical point of view, it's really not an issue to remove a lead which has been implanted a couple of weeks ago. I would say that from a clinical point of view, we didn't really, we didn't do it in practice in my center until now. Maybe we will change our practice in the future. But I think that really what is important is that we emphasized having an echo before, and I remind that this is a guideline coming from the pacing guidelines of the ESC, for example, to have an echo before. This is very important in order to exactly adapt the pacing implantation to the constatations during the echo. And then after, I think we need more scientific evidence before removing a lead, but it's something that we should take into account for sure.
Excellent. Thank you very much. Let's move to the next topic. We promised you that we will talk about valve-sparing pacing, how to pace without touching the tricuspid valve. I think a very interesting topic, and that's the one from Blandine Mondésert. Blandine.
Oh, thank you for the introduction. Can I get my slide, please? So I'm going to discuss for the next couple of minutes about how to avoid the tricuspid valve with a pacemaker or a defibrillator. Here are my disclosures. And we are going to review the technique and to be considered to avoid the tricuspid valve in patients with tricuspid regurgitation or after the transcatheter tricuspid valve intervention. So here it's from the paper published in Europace, and we have the different solution to avoid the tricuspid valve. So you can see on the left side of the slide the pacemaker alternative, so the ventricular pacing through the coronary sinus, the epicardial pacing, the leadless pacing, and the YCRT pacing with the leadless pacing. And on the right side of the slide, the ICD alternatives, so the sub-Q ICD, the extravascular ICD, the sub-Q and the leadless with the Empower system, and the transvenous ICD with a coil in the azygos vein. So I am going to give you some example of that kind of patient and the possibilities that we have to avoid the tricuspid valve. So here it's the epicardial lead. So most of the time you need at least a thoracotomy for that or a sternotomy if you want to have a CRT device in place. So it's more the surgeon's work to do that. We are involved most of the time in threshold in that time, but we are not involved in the implantation in our patient. Next slide, please. Okay, here the coronary sinus. So I put an anatomic view for the coronary sinus. And since now, a couple of years, we have a new lead with a little screw in. So it increases the stability of the lead. And we, thanks to that kind of device and leads, we are less anxious about letting only one lead in the coronary sinus. There is less dislodgement with that, and so we have a more stable pacing. And I just want to remind you that going in the coronary sinus, we are not crossing the valve. The coronary sinus is in the atrium, in the right atrium, so we can totally avoid the coronary sinus, the valve, the tricuspid valve at that time. Next, yeah. So here it's an example, a patient who already have some tricuspid clip, and he needs a pacemaker after the tricuspid clip. So we put, actually he already had a temporary pacemaker on the left side of the slide, and we put a lead in the coronary sinus, and you can see that on the right side of the slide. We don't cross the tricuspid valve repaired with the clip. The other option, and it's now a very big game changer for us, it's the leadless pacemaker. So in the beginning of the 2010, we have the NanoStim, and then from Saint-Jude Medical at that time, and we have a recall for the battery depletion and the ducking button dislodgement. And finally now, today's, we have two kind of pacemaker, the Medtronic one, the Micra. for the ventricle pacing, so the VR, or for the AV micra, so we can sense the atrium and pace the ventricle, but we can't pace the atrium with the micro AV. And now we have the AVIR from Abbott, so we can implant just the leadless in the atrium or just in the ventricle, or we can pair together the two pacemakers and have the first real DR leadless pacemaker available. A couple of in 2019, there is a paper about 53 patients who had the leadless micro at that time, and some of them have an increase of tricuspid regurgitation. And actually, the positioning of the leadless, especially if you untrap the papillary muscles or if you're very high on the septum, can induce a more important to increase the tricuspid regurgitation. So you have to be careful about your positioning and your implantation techniques as well. Here is some example from, once again, the paper in your pace about how to implant our patient after the percutaneous tricuspid valve. So in the panel A and B, it's with the leadless, and it was a micro at that time. And panel C and D, it's with a coronary sinus leads, and on the panel D, you have two different leads in different branch of the coronary sinus at that time. In terms of defibrillation, we have now, since the 2010, the sub-Q ICD, so the subcutaneous ICD with the device outside of the chest, outside of the heart. The box is on the lateral wall of the chest, and the lead is just on the sternum. So you don't have anything in the middle of the tricuspid. Here is the one of the case report that we have done more than 10 years ago now with the first sub-Q ICD and leadless. That was a nanostim at that time. There is no communication in between the two devices, but there is cohabitation and it's feasible. And now we have the modular system with the leadless named Empower from Boston Scientific, coupled with the sub-Q ICD, and now there is a communication. So far the communication is only one way, sub-Q to Empower, but perhaps in the future we could have the both-way communication, and actually it allows us to have the pacing backup and ATP in case of monomorphic VT. That system is not approved yet, neither by the FDA than the European regulation. Here it's one of the cases that we have done in the trial for the modular ATP. So you can see the sub-Q ICD in position with the box on the lateral chest and the lead just before on the sternum, and you can see the leadless on the septal wall on the right ventricle. And here it's an episode that the patient have. You can see in the middle of the slide the ventricular tachycardia, and then the ATP and the return in sinus rhythm for the patient. We have another option for non-transvenous ICD. That's the Medtronic extravascular ICD, the EV-ICD of the Aurora. So it's mainly the same aspect than the sub-Q ICD, except for the lead. The lead is under the sternum and not anymore on the sternum. So we have to implant the lead in the chest, but outside of the heart, and we don't cross the tricuspid valve in that case. And here it's a case report that we have published recently with a leadless pacemaker in the atrium, coupled with the EV-ICD. So once again, no communication, but cohabitation, and it's feasible. And so far we don't have any interference and interaction in between both of the devices. In conclusion, in case of tricuspid regurgitation already present at the time of the device implant, you have to think outside of the lead world. So you have to think about leadless coronary sinus leads or non-transvenous ICDs. In case of transvenous ICD that you have already implanted, I think we should check the transthoracic echo after the implant. The delay is not well known so far, but at least 1 or 3 months after the implant. And in case of transvenous leads and transcatheter valve replacement, then you have before the procedure of TTVR to discuss with your colleagues in EP, in interventional cardiology, to find the best option for the patient in terms of different options of pacing and defibrillation. And I think it's very important to discuss that in order to avoid to jail some leads in the patient. So thank you.
So thank you very much, Blandine. Excellent presentation. A lot of option. It's really fantastic to see how much option you have, cohabitation, and many other options for patients to avoid the tricuspid valve. I think that's something that we will do more and more. And maybe let's think, as you said, outside of the lead world. And maybe in some situation, if we may ask you in precise clinical situation, which valve sparing strategy you will use. For example, Blandine, in a patient with a sick sinus, which valve sparing strategy will you use in that situation?
Actually, more and more often now we are thinking about just atrial pacing in that case of just sick sinus syndrome without any proof of AV block. And last weekend we have our meeting in San Diego, the HRS meeting, and there is a lot of discussion about just having a lead in the atrium, so transvenous lead or a leadless pacemaker in the atrium. If you check the Wenkobat and that the Wenkobat is good and you don't have any proof of AV block, I think only the AAI pacemaker is a very good option.
And if you have a patient with reduced left ventricular function needing pacing, which valve sparing option in that situation?
In that situation, I think the coronary sinus leads is the best option. Especially, we have some proof that the LV only pacing is better than the RV only pacing, but the biventricular pacing is better than the LV only pacing. So in that case, perhaps we can try to have 2 different leads in the coronary sinus in order to try to have a better resynchronization in that kind of patient.
You know, a situation we have a lot actually are patients, for example, with FPEF, because that's associated with tricuspid regurgitation. And these patients, when they need 100% pacing, are a little bit of an issue as well when you need to go valve sparing. So what would be your choice in that situation?
In that situation, I think it depends. I will try to avoid as well the tricuspid as long as I can. So perhaps a leadless pacemaker in that kind of patient, if they don't have huge QRS, it could be a good option. The left bundle pacing could be as well an option, but in that case, you have to cross the tricuspid. And we have now some data on the left bundle pacing that the higher you go in the septum, the higher risk you have to increase the tricuspid regurgitation or to actually to have an impingement of the septal leaflet or some issue with the septal leaflet. So LBB, it's the new technique for pacing that everyone want to do, but we have to be careful once again about our techniques and what we are doing with that kind of pacemakers.
So maybe we can ask Jean-Claude and Julien to tell us what is the most used valve sparing technique at your center, Jean-Claude, for example.
Well, it's exactly what Blandine said. It really depends on the kind of patients, but I think that really we are on the rise of using the leadless pacemakers, because we now have this leadless pacemaker which allows for right ventricular pacing, but also the ones which allow for dual chamber pacing. This is very new, and this is something that we use very frequently. In case we want to pace the left ventricle, we go, of course, to the branches of the coronary sinus also.
And you, Julien?
No, I agree. It's pretty the same. We prefer probably leadless pacemaker if possible after any transcatheter intervention. While after transcatheter intervention, it may be difficult to implant leadless pacemaker, and probably we'll move more towards coronary sinus stimulation.
With the possibility to implant just one lead. We just learned this from Blandine. So we are still waiting for your question, and it's a quite technical subject, but I think very important one. And Blandine has explained this really in a beautiful way. Jean-Claude, do we have a question?
Yes, I think we have a question, and this question is for Fabien. We are aware of the issue with artifacts in the case of cardiac MRI, but could it play any role in this? I mean, we didn't discuss about cardiac MRI.
It's a good question. I know that it's written everywhere that MRI is the gold standard. I truly believe that MRI is very interesting to have RV and RE function and volume. It's very useful for this. To assess TR, it should be discussed. And when you have pacemaker leads, the quality, because you have to know that 90% of patients have atrial fibrillation with severe TR. I told you that 1/4 to 1/3 had pacemaker, and that are issues. So I'm not sure that MRI is the best exam, and I would prefer to say transthoracic echo first, transesophageal echo as second, and as third CT, especially if we consider a transcatheter replacement. So I would suggest more CT than MRI to assess the position of the lead.
No, I think availability and the feasibility of MRI in the presence of pacemaker is
but also its impact. Also, if you want to choose the device, you will use the CT, not the MRI.
Next question?
Yes, and maybe this is a question for Blandine. Blandine, you already discussed the role of left bundle branch area pacing. Can you expand a little bit on this? Because there is a question on the exact role of left bundle branch area pacing in these patients with tricuspid regurgitation or tricuspid interventions.
So the left bundle pacing area, it's most of the time it's a lead on the septum on the left bundle branch. Most of the time, before a couple of years, we use a very tiny, thin lead, the 3830. It's a 4 French lead. So we thought at the beginning that there is no interaction with that kind of leads and the tricuspid valve. But actually, because of the positioning of the septum, and we have to turn very fast after the valve to get the septum and the good positioning to get the left bundle pacing in that kind of patient, we can increase or actually create a TR in that patient. If we are going more distal and more on the posterior fascicular branch, then perhaps the interaction with the tricuspid valve is a little bit less prominent, but it's there is something that we are looking at when we are doing left bundle pacing, and it's a little warning that we get a few months ago.
One more question, Jean-Claude, and then we move.
Yes, there is one more question. It's about what to do, and this is probably for Blandine, what to do in a patient with a pacemaker lead which was implanted 2 years ago, more than 2 years ago, and this patient should receive a transcatheter tricuspid valve intervention. I mean, it's not exactly the topic you discussed, but still it is a question.
Actually, it's more a question for you, but actually, if I try to assess in every patient the risk of extraction, and I think a 2-year-old lead is not a very high risk extraction procedure. So I will try to remove that lead and implant a leadless before the intervention of the tricuspid. Most of the time, I try to ask my intervention colleagues to wait 4 to 6 weeks before doing the procedure on the tricuspid valve after I put the leadless in. Sometimes we don't have the time to wait, so I ask them to be careful and not to dislodge my leadless. But in a just 2-year-old lead, I would recommend to extract the lead and reimplant a leadless. If the patient still needs some pacing, sometimes we have as well to reassess the indication of the pacing or defibrillation at the time of the intervention.
Very important.
So Blandine, excellent answer and a perfect transition to the talk by Jean-Claude on the transvenous lead extraction, a very important topic, I think. So Jean-Claude, I give you the word.
Yes, thank you very much. Yes, transvenous lead extraction is really key in the discussion about tricuspid regurgitation and tricuspid interventions. These are my disclosures. We really wanted to emphasize in the document, and this is a central figure of the document, we really wanted to emphasize the risk of jailing a lead. Jailing a lead carries many risks. One of them is, of course, a mechanical stressor on the lead, and this may lead to lead dysfunction in the future. A second one might be a lead dislodgement or a lead tension, which might be a problem or an issue not only for the lead but also for the tricuspid valve intervention itself. And also what is important is that when we jail a lead, it carries a huge risk of impossibility to remove the lead in the future. And there is a situation in which it's very, very concerning, is the situation of infection. You know that it's impossible to cure a patient with a lead infection without removing the device infection, the lead, but also the can, without removing the lead. So it's really a huge risk that we take when jailing a lead. And this is what is on this figure. But removing a lead is really something which is tricky. It's tricky, and this is what we discussed from the beginning of this discussion today, because there are many adhesions of the lead, and these adhesions are not really something that we can know in advance. In some patients, we will have a lot of adhesions inside the ventricle, for example, like on the left part of this slide, or inside the atrium, as we see on the upper part of this right panel. And also we have adhesions on the vessels, including the superior vena cava. And this is really what makes the lead extraction very difficult. This is also the reason why we use a lot of tools for lead extraction. I don't know if you are all familiar with these tools, but the general principle is that we have to dissect, we have to really free the lead from the vessel and from the heart, and we have to use what we call sheets, dissecting sheets. These dissecting sheets might be passive. These are the ones that we see on the upper left panel. It means that you have to make rotation with your hand and to try dissect the fibrosis. We can also use the evolution sheet, which is like a bladder, which is moved from the finger, and this bladder is cutting the adhesions. And we can also use the laser, which is an energy, electrical energy, light energy that makes a very thin dissection of the lead. You can imagine that using this kind of tools in a vessel or in the heart carries some risk. There is a bevel, there is energy, there is a risk of cutting not only the adhesions, but cutting also the vessel of the heart. And this is really what is known when we perform a lead extraction. Here you have an example of a laser lead extraction, and you see clearly with the upper yellow arrow that there is here a close adhesion between leads, which is something which is not unusual. And it might be impossible to remove one of the leads without removing the other one. It makes the technique more difficult. And of course, the laser sheets, which is marked by the white arrow, is cutting these adhesions. And you see that adhesions are also present inside the ventricle, at the very end of the lead. And this might be an issue when we want to remove. So really, these techniques are techniques that we should use with caution, because we can have some damage from the heart and from the vessel. And what about the complications? It's about 1.7% major complications in our last registries. The ELECTRA registry, European registry, mentioned 1.7 major complication rate, and death is 0.5%. This is very important, because we have really to tell the patient and to tell our colleagues that our intervention may carry some huge risk. You have some factors which are correlated with the complication or death risk, but I would say that if we want to make it simple, it's all about the lead dwelling time, when you have more than, let's say, 6 or 10 years for a pacemaker lead, or more than 12, 15 years for an ICD lead, it carries a strong risk. And also it's a matter of number of leads that you have to remove. And also, of course, many factors are related to the patient or to some technical issues. So we wanted in this consensus, in this scientific statement, we really wanted to make it practical, and we wanted to have a discussion about when to have transcutaneous, transvenous lead extraction in some patients. We already saw that there are some red or orange flags for lead jailing. In case there are present these red or orange flags and lead jailing is something that we do not want, we should go to tricuspid lead extraction in many of the patients, except the ones we will go to edge-to-edge repair of the tricuspid valve. When there are some flags, and this is something that we will discuss in the next presentation from Fabien, when there are some flags, the discussion is really more difficult. What to do? Really, we have to discuss all together to take into account the risk of lead extraction. Is it possible to do it? Yes, in some cases we will do it, but sometimes we will not do it and we will accept lead jailing and all the issues coming with lead jailing. And also, a very important thing is what to do when a lead is jailed and you have an indication for, let's say, removing the lead. What to do when you have a lead with malfunctions or a device upgrade to perform. In general, in this situation, you cannot perform the lead extraction, and so you will go to some technique like the ones which have been presented by Blandine about valve sparing. But the main issue is when a patient has an infection. In this situation, it's really a tricky issue. What to do? In some patients, we will do nothing except giving antibiotics. And we know that this strategy is a long-term suppressive antibiotic therapy is not something that we like. In some patients, we will discuss lead extraction. For an isolated pocket infection, we will go to lead extraction in very, very selected centers because it's quite difficult to perform lead extraction in this situation, and we will leave the material for the tricuspid valve repair in place. And in case we have a tricuspid endocarditis, we will have to remove all the material, including the leads, but also the repair system, which is a situation really very, very difficult. So please think in advance about not jailing a lead because the situations might be intractable situation. Thank you very much.
So thank you very much, Jean-Claude. Very, very clear. Also, this algorithm that you can find in the publication. Julien, you have a question.
Yeah, Jean-Claude, do you have any requirements before lead extraction, especially for imaging assessment or?
Well, to be honest, we don't use a lot of imaging before lead extraction in our center. Some centers use CT in order to see if the lead is inside the vessel or outside the vessel, because this is really something which makes a risk very important. But in general, I would say that, except of course for assessing the valve and for the other reasons, but not really for lead extraction.
Okay.
Any question from the audience, Jean-Claude?
Yes, there was a question which might be for everybody. In specific cases, is a tricuspid valve a clip of the valve an option that we can consider in patients with leads?
Yeah, it's what I previously mentioned. In fact, it will depend on two things. First, the mechanism. If the lead is inducing the TR, then you should not consider a transcatheter edge-to-edge repair. And the second point is the location of the lead. If the location is in the commissure, posterior septal commissure, it won't prevent any implantation of a clip, while if it's anteroseptal, usually it will be difficult to implant. So the mechanism and the location are the two things to consider.
I agree, and I think edge-to-edge repair is a good option for this patient if it's not adherent to the leaflet. The lead can be moved as well, so that's definitely an option. Jean-Claude, other question, or should we move to the case?
Maybe we should move to.
Okay, so let's move to the case. We wanted to show you a case that will a little bit summarize all the discussion we had. Quite complex case, I would say, but we will go step by step and have a discussion also among us to see how we can best manage this patient. So that's quite a young patient, 60-year-old female patient, and she had a difficult history with Hodgkin lymphoma, pulmonary involvement. That was about 20 years ago. Chemo and radiotherapy have been done. She's in complete remission. So that's an old story. But this story has a lot of consequences on her health, as you can see, because in 2019, she had probably a post-actinic progressive left ventricular dysfunction with an LVEF of 30%. And also a severe secondary mitral regurgitation. She had got a replacement of the mitral valve and developed atrial fibrillation in this context. And then the doctors treating her saw that it would be appropriate in that situation to, because of the dysfunction of the left ventricle that was not improved after valve replacement, to implant an ICD. So that was 1 year after actually the story with the mitral valve. And the patient had some complication with this ICD, in particular in an inadequate shock due to an AV node re-entry tachycardia in 2021. And then the story goes again into valvular heart disease, probably also because of the radiation. And you see that the patient got a TAVI, an aortic valve replacement, in 2023. And so we are with this situation. The patient comes back with severe tricuspid regurgitation that may be ICD related, as you can see on these images. On the left, you have the image in 2019 before the ICD lead implantation. And 5 years afterwards, you see that there is a progress of tricuspid regurgitation, in particular around the lead. And the patient has also is, of course, on medical treatment because of the left ventricular dysfunction and has a quite high dose of diuretics and chronic renal failure. So maybe we can discuss, after looking at these more detailed images, what would be the management of the patient. I think, Julien, these images are showing that the lateral leaflet, actually probably the posterior leaflet, is constrained by the lead, but we don't see on these images, and in particular on the true view, a clear adherence of the lead to the leaflet. But you see this extrinsic jet that is probably a mechanical consequence of the ICD lead placement. So maybe my question to you, Jean-Claude, and then Julien and Blandine, quick description of your strategy in that situation: young patient, ICD lead, TR evolution and progression after ICD implantation, some complication from the ICD as well. What would you do in that situation?
Well, in this situation, really, I would have a discussion with Julien in order to know what is the mechanism of the tricuspid regurgitation. But I would really be in favor of extracting the lead. This is a lead which has not been implanted many years ago. It's only 5 years when we are discussing the case, and the patient is still a young patient. So in the future, if we leave a lead and we really jail a lead, it might be a major issue. So I would go to TLE after, of course, a discussion with Julien and with the patient, because this patient probably is very aware about the risk, and she had many issues with her health. So now she's aware about anything, and she will enter into the discussion.
Jean-Claude, a difficult question I will ask you now, I tell you, but if the lead, this ICD lead, will be used by the patient, for example, would that be another situation in that situation? You would go for extraction and one of these very clever ICD system we have seen by Blandine, or what would be your thought in that situation?
I would have exactly the same attitude. I think it's even more important in a patient who already had a treatment from the ICD and an appropriate treatment, of course, to have a lead which may not dysfunction. So for sure, I would remove the lead and ask Blandine to implant like a subcutaneous or something she showed us.
Julien?
I would agree with Jean-Claude. First, I think the patient has a prohibitive surgical risk despite a young age with prior Hodgkin, prior surgical mitral valve replacement, TAVR. So we'd consider transcatheter options. And considering that she's very young, only 60 years old, probably, if feasible, I will discuss an extraction of the lead.
Good. Blandine?
I would probably extract the lead as well. I will check if the patient needs any pacing to try to choose the best option after for reimplantation, SICD alone or SICD plus something. Because she has a previous open heart surgery, she has a contraindication so far for the new EV extravascular ICD.
Yes, Julien?
But just to be clear, the goal of the extraction is not to correct TR, it's just to avoid keeping this device with the risk of endocarditis in the following years. That's the goal. The goal is not to decrease TR, but just to avoid the risk of endocarditis in the future.
And one other point, of course, the pacing in that situation is extremely important. But what is also important is the selection of the right device for this patient. So what would be your suggestion, Julien? It would be repairing the valve, transcatheter. I mean, you mentioned the surgical risk is high, so probably that's not an option. Or replacing the valve. What would be your thought here?
In fact, it's difficult to define it before the extraction because we have to reassess TR after the extraction. But usually when you have an adhesion, it will remain some degree of fibrosis and the mobility of the leaflet will be significantly altered. So usually you don't have any other option than replacement in this situation, but I have to be cautious and to reassess it after the extraction.
Okay, thank you very much. Very interesting discussion, I think. So let's have a look at what we did in this young patient. So actually we did exactly what you were mentioning. So we extracted the lead with a particular technique from transfemoral because of the risk, the occlusion of the vein, because of the angulation. So our EP specialists were thinking that this is the best strategy, and that was actually quite successful. And then we waited for also to see how the anatomy is evolving. If we have, but you mentioned that our hope to improve TR just by this extraction was not very high. And in fact, actually the patient did not improve and still had severe TR. That was several months after the extraction. And we went actually for an evoke implantation because of the gap, because of the anatomy, the complexity of the jet. So we replaced the valve from the transfemoral access. That's what you see on the right side, with ending actually with the patient having all three valves replaced, as you can see, and which is not a very unusual situation in patients with post-actinic valvular disease. So that's the situation, but the story is not at the end because you see that we have a perfect valve function. So the valve is functioning very well, but you see on the right side that the AV node is not functioning anymore now, and we don't have a pacing lead, either jail or inside of the valve for now. So we need in that patient, because he was symptomatic, bradycardic, we needed actually to go for a pacing strategy, having a valve in place. So what would be your thought with this new situation, Jean-Claude?
Well, first of all, it's a case, a difficult case, but it's not a completely unusual case because this patient is just collecting more and more issues after each treatment. And in this case, there's complete AV block, so now we need pacing. And in case we need pacing, I think the option that we would choose would be to go through the coronary sinus in this situation in order to pace the left ventricle because this patient has a severe left ventricular dysfunction. So I would favor this kind of implantation. I would say that leadless pacing is very difficult in this patient with an evoke valve because it's very difficult to cross the valve, and also the leadless pacemaker will not provide a very physiologic pacing of the right ventricle, so a lead in the coronary sinus.
Because of the left ventricular function.
Yes.
So Julien, I think you agree?
Yeah, it's very important to mention that after transcatheter replacement, like after surgical replacement, it's very common to have an AV block and to need pacemaker stimulation. And in this situation, usually we do the same with pacemaker and coronary sinus. And usually EP colleagues ask for a pacemaker to be performed just after the intervention because usually you have a large footprint and to be sure about the pathway. To get the proper access for the coronary sinus.
Blandine?
I will choose as well the coronary sinus. If the patient has a normal ejection fraction, perhaps I would choose more the leadless pacemaker at that time combined with the sub-Q ICD. And perhaps in that kind of patient with the evoke and the tricuspid valve replacement, the jugular approach for leadless pacemaker could be an easier way to put the leadless in the right ventricle.
That's a very good suggestion. I will show you what we did. Actually, we did not do what you were suggesting because our EP colleague were concerned about the left ventricular function, as you are, but wanted to have more physiological pacing and went for an LBB-urea pacing. So what are your thoughts on this, Jean-Claude? Of course, the disadvantage of this is that you recross the valve, but I will show you the final result, actually, which is very good. You have to believe me because the video is not working, but the patient had really very low TR in the middle of the valve, despite having a new lead crossing the evoke valve. Maybe some reaction on this, maybe unconventional way to install pacing in patients with tricuspid replacement?
No, it's good to see that this is a possibility. We did it for many years with surgical tricuspid prosthesis. Why not to do in this kind of patients? And if you want really to pace the left bundle area, for sure this is the only option that you can use. I would say that we should be very cautious with the patient because if we need to remove the lead, it might be also an issue for your prosthesis, the prosthesis that you implanted. So I'm sure that you had a thorough discussion, you all discussed, and the decision was taken because of left ventricular ejection fraction decrease in this patient.
Yeah, exactly. So you see here the final result that is actually very good. But of course, we will follow this patient further to see how is the durability of the valve, how is this evolving, and learn a lot from this case. Jean-Claude, we have a few minutes left. Maybe there are some burning questions from the audience before we close.
Yes, there is a discussion. There's not a question, but a commentary which is interesting, telling that it is possible to go through the EVOC for implanting a leadless pacemaker. And this is very important because I just wanted to discuss it. It might be easy to do it, but it might be extremely difficult. And last week we had an example with my friend Pascal Defay in Grenoble, and he really had to work for 4 hours for crossing the valve. So we should take it into account. It might be very difficult, and some specific techniques have been described using multiple tools, using lasso and all these things. So I'm not sure that this is really true in all cases. There is a question about lead jailing also. Are there any data assessing the risk of lead jailing? So this is probably a question coming from an interventionist because they are not really sure that there are issues about lead jailing. Do we have data about this? If yes, does it have really any outcome relevant results such as MACE? Maybe Blandine, you want to answer this question or?
I can begin and you can complete my answer if you want. Yes, there is some small data because actually, and old data about the time where there are surgeons jailing the leads as they are doing valve replacement. Actually, as we said in the paper, there is data on electrical performance of the lead. And the ICD leads are much more fragile than the pacemaker leads. If the patient is dependent, you have to be very careful at that time just to be sure that you don't lose any pacing, any threshold, any increase in the threshold after the jailing leads. In terms of infection, as you already said, it's a higher risk of surgery because we can't do anything if the lead is infected to remove it via percutaneous way. But in terms of MACE, I don't recall having any data on that. I don't know if you do, Jean-Claude?
No, I agree with you. The risks are the one you discussed. And I think that the infection risk is really the major one. We don't have any data on this, of course, because it's a recent technique. But by analogy, you have to know that it's a complete contraindication to entrap, to jail a lead with a stent in a vessel, like in the superior vena cava. So it might be exactly the same for a stent on the valve. This is the reasoning that we had on the paper, but there is no scientific data, of course, on this. This probably will be the case in the future because you are collecting many data in your registries, I think, Fabien.
No, exactly. So we will look at this, of course. There are some data from valve-in-ring or valve-in-valve procedure on the right side showing that this problem is not negligible, so it may exist. Of course, valve-in-valve is a particular situation because the lead is between metals, and that's something quite aggressive. But that's something we need to look at, and that's something also we need to discuss together because as you said, the risk of venous extraction is there, in particular in our polymorbid patient. So we need to come to a consensus together what is the best strategy. So I would like to, Julien, you have?
No, I fully agree.
Perfect, perfect. So I would like to conclude. It was a very nice discussion. We learned a lot. We learned with Julien how to diagnose and avoid leaflet interaction with imaging. We learned with Blandine how to pace without touching the tricuspid valve. Very nice talk. Think outside the lead world. I will take this with me. And finally, we learn about transvenous lead extraction. So I would like to thank everybody, Julien, Jean-Claude, Blandine, and you all for looking at this program that will be, of course, available on PCR online. And we will hope to see you soon again. Thank you very much.